Early diagnosis, early medication for people who have chronic inflammation is what it needs to be done earlier, quicker.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Dr. Mona Dagher and myself, Dr. Hadi Saheb.
Bienvenue à EyeCan, un balado sur l'ophtalmologie sous un angle typiquement canadien avec le Dr. Hadi Saheb et moi-même, Dr. Mona Dagher.
Season 4 of the EyeCan podcast is brought to you by Baylor Ophthalmology. We thank them for their support. Nous aimerions remercier Baylor Ophthalmology pour leur support de la 4e saison du balado EyeCan.
We will share our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers. Hey there, eye care enthusiasts. It's Mona and
Hadi, back at it again with EyeCan.
You know it, Hadi. Today's episode is going to be a real eye-opener. Pun intended.
Mona, always with the puns. I promise, folks, today's discussion will be just as sharp as Mona's great wit.
Hey, we're here to keep it both informative and entertaining, right?
Absolutely. So whether you're a seasoned ophthalmologist or just as fascinated by eyes as we are, you're in for a treat.
Dr. Louis Racine is a cornea transplant surgeon at Centre Hospitalier de l'Université de Montréal. He completed his medical degree and residency in ophthalmology at Université de Montréal. Following this, he was awarded a grant to pursue his fellowship training in cornea, cataract, and refractive surgery at Baylor College of Medicine in Houston, Texas, as well as at the renowned Rothschild Foundation in Paris, France. Since 2003, Dr. Racine has been a beacon of excellence in refractive surgery, having performed tens of thousands of procedures with unparalleled precision and expertise. His pioneering spirit led him to become one of the first surgeons in Montreal certified on the femtosecond laser. And in a remarkable testament to his commitment to his craft, Dr. Racine underwent PRK surgery on both his eyes in 2004, further solidifying his empathy and understanding of the patient experience.
In Canada, he is also one of the cornea specialists with the most experience treating patients with keratoconus through use of corneal collagen cross-linking. Dr. Racine participates in shaping the future of ophthalmic care through his involvement in clinical trials. Notably, he was involved in the United States FDA trials for the Acrosoft toric intraocular lens, contributing to advancements in this technology. As an associate professor of ophthalmology at the Université de Montréal, he plays a pivotal role in teaching the next generation of ophthalmologists. His passion for education is palpable. He is great at sharing his vast knowledge and expertise with residents and fellows, particularly in the intricate realms of cataract surgery, corneal transplant, and complex anterior segment surgeries. An expert in the field of dry eye syndrome, the topic of this podcast, Dr. Racine is at the forefront of a Canadian group dedicated to evaluating innovative treatments for dry eye disease. A sought-after lecturer and published author, Dr. Racine's insights have captivated audience across Canada, the United States, and Europe. His work, including contributions to esteemed publications such as the American Journal of Ophthalmology, underscore his unwavering dedication to advancing our field. Louis, we're excited to have you and welcome to the EyeCan.
Thank you. Excited for having me on the podcast. Thank you.
So Louis is a non-dry eye specialist. I'm a glaucoma specialist. I hear about dryness complaints all the time. And so do all these patients that are complaining to me about drying and burning, do all these patients have dry eye disease? And what is the definition of dry eye disease for you?
Well, dry eye disease is a chronic inflammatory disease, but a local disease limited to the ocular surface mostly. So dry eye can be a symptom every now and again, but someone who has dry eye disease has a chronic and lengthy stage of this ocular irritation. And it's usually because of insufficient, inadequate, or we might say suboptimal quantity of tears or suboptimal quality of tears. And we'll get to that later. So chronic inflammatory localized surface disease, this is what dry eye is. And it does affect a lot of people. 2020 Canadian numbers show that about 6.3 million Canadians suffer from dry eye, which is about 20% we have 25% of female and 18% of male. So 6.3 million Canadian people are suffering from dry eye disease. And as you discussed earlier, not everything is dry eye. The common symptoms, as you actually talked about, discomfort, foreign body sensation, redness, greediness, are the kind of classic dry eye symptoms. But other symptoms are a little less common, such as tearing. So tearing, actually making more tears, usually is not necessarily thought about to be dry eye symptoms, but an eye that's irritated will make a tear to compensate, but that tear may not be of good quality or good quantity. Eye fatigue is also another symptoms of dry eye, and one of which is less known is visual fluctuation, which is the eye adjusting to focus, or even drop of vision in severe dry eye is also something that's worrisome.
A few questions to unpack some of what you've just said. I'm curious to know how you approach talking to patients about tearing being a symptom of dryness. It's such a challenging thing to try to break down for a patient. And often when I recommend to a patient to use artificial tears, they'll respond, "Well, I'm already tearing. Why should I put more artificial tears?" What's your spiel to patients when they're bringing that forward to you?
Well, yes. So a little bit like we said, the question is your tearing of good quality? Now, we do have some devices that can measure this, but on a day-to-day basis, we don't measure this. But yes, so the question with patient is, well, if your tearing is enough, you wouldn't be here or complaining of irritation. So if your eye would make enough tear or good enough tear, you'd be okay. But if you still have symptoms in between those tearing, something's going on. So your own tear might not be sufficient to lubricate or repair the irritation or the chronic irritation you may have. So yes, so if someone is tearing and comfortable, well, the discussion is over, but there's usually something else. And so yes, that tearing of lesser quality tear is usually where I find the explanation for those patients saying, your tear are not of good quality. Let's give you a good lubricant that actually has good quality and quantity.
And then the other symptom I wanted to unpack was the variable vision. Technically, when a patient is having an intermittent vision loss or intermittent blurriness, there's a category of symptoms, transient visual disturbances. They could have, really serious causes, like something neurologic or vascular that really would need to be worked up in an urgent way. When you're kind of in the trenches in the emergency clinic and somebody comes in with, transient visual disturbances and you feel like it's dryness, what's your approach to making sure you're not missing something, more worrisome? Like when do you look at a patient and say, I don't need to work this up. This is dryness. Let's move on and focus on treating dryness versus taking a step back and saying, okay, well, this might not be simple dryness and we need to do something else.
You ask a very good question. Our job is to eliminate the worrisome conditions, first of all, like neurologic, but a few key things of the questionnaire that can actually influence and pushing this toward dry eye. For example, visual fluctuation that is more at the end of the day compared in the morning. Visual fluctuation when people have a sustained visual task, such as computer. And people will actually say that when I blink, it actually clears up. So when blinking clears up visual fluctuation, that steers me towards ocular surface. So either tear volume or tear quality. So visual fluctuation, end of the day, a different visual task, and also usually remedied by blinking or using artificial tears, usually steers me in the ocular surface direction.
Those are great pearls. I'm sure we'll save a few blood tests and scans for many of our patients taken care of by our listeners. Thanks, Louis. Those are great pearls.
And Louis, what are some common misconceptions about dry eye?
Well, one of the misconceptions about dry eye is it's a quick fix to treat. But the also misconception is it's complicated to treat. And the whole point of this is it is a chronic disease, and dry eye takes a long time to set in. It takes, years, months to set in. And by the time people have chronic dry eye, it's been going on for a while. And so there's no quick fix like high blood pressure. You take a pill, your pressure's fine the next day. This is different. This takes a long time to stabilize and to alleviate. And since dry eye is a multifactorial disease, which means It comes from the ocular surface. It comes from the dry hair around us, the dry environment. It also comes from the activities and hobbies. It is hard to treat everything. So imagine someone who works at a computer all day, then comes home and relax, scrolling on the phone, and then eats, and then relax watching TV and streaming. I mean, they've been watching screens all evening and all day long. And we know that the normal blinking rate is about 6 blink every minute. When you read a material, you blink about 50% less. And when you're actually looking at a computer screen, your phone or a tablet, your blink rate decreased by 70%, which means that instead of blinking every 6 seconds, you blink every 20 seconds. And we know physiologically that the tear can actually hold about 15 seconds without blinking, which means when you have dry eye, your tear evaporates much faster, 5-10 seconds. And if you don't blink every 20 seconds, there's a long period of time where your eye has a decay of the tear film that evaporates. And this is what creates visual fluctuation. Just imagine, getting your wipers in your car on, but without using fluid. Well, you're actually smearing things. So people who actually don't have good quality or good quantity of tears, that's what they experience, that blur that comes in, and that's visual fluctuation in a nutshell.
That's a very interesting way of putting it. Are there any specific risk factors, and you touched upon this a bit, or age groups that are more prone to developing dry eye disease?
Yeah, we know that, as you age, the more you age, the more dry eye is prevalent. And so there's two types of dry eyes, the type that you actually produce less tears, but also the type that you have less good quantity of tears and tears evaporate. And so these are evaporative and production of tear lacking. These are the two types of dry eye. And as you get older, they tend to coincide. And most people have about 80% of people have mixed dry eye, which is evaporative and production. And so the age and female gender is a risk factor. Other associations are systemic inflammatory disease, such as Sjogren's syndrome, which is actually a disease of dry eye, dry mouth, and dry mucosa all over the body. Rheumatoid arthritis also. So any disease like lupus, rheumatoid arthritis, we actually have inflammatory biomarkers systemically can influence the ocular surface. Inflammatory bowel disease, Crohn's disease, ulcerative colitis are all disease that can have dry eye as a symptom. The rest is what we discuss is habits, but also the environment. So we live in a province where we have winter. In winter, we have heat. And with that comes lower amount of relative humidity. So just by living in Quebec, we are exposed to a lower relative humidity. And sometimes in the work environment, hospitals mainly are very, very dry. So wherever people are working, and it influences a lot. During pandemic, people got to work at home, and some people with dry eye actually got better because they got better control in their environment. And so we saw that as well. We also saw people working more at their computer, and so they got a little bit worse. So whatever you do, wherever you do it, also influences your ocular surface.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we will try to incorporate them into future episodes.
I'm Ravi Dukaran, and I listen to the EyeCan podcast.
What are your top treatments that are currently available for dry eye disease? And this would be whether it's over the counter or prescription. What are your current go-to treatments for dry eye?
So that I usually go by 3 easy steps, and the first step we just discussed is more of a lifestyle change. People who wear contact lenses to put it aside, to start lubricating the eye regularly with over-the-counter drops, and we can touch on this more specifically later. Increase humidity level, and that's kind of hygiene level. Step 1. Afterwards is regular lubrication with better artificial tears, preservative-free, and artificial tears containing ideally hyaluronic acid, which is a better lubricating product. So that's kind of stage 2 of lubricating better tears. And the last stage or later stage is anti-inflammatory stage. We did say that dry eye is a chronic inflammatory disease. And in order to treat this chronically, you need anti-inflammatories to the ocular surface. And namely, there's usually 3 categories: cyclosporin, lifitegrast, and cortisone, which is usually used for a short period of time. And so these are the categories of treatment, the 3 first steps. There are other steps for more advanced dry eye, but this is what we do. When people come in and complain of dryness, we lubricate optimally, choose an artificial tears that is good for them, high frequency and regularly, even if they don't have symptoms every day, so that they have relief every day.
And can you discuss any recent advances or emerging therapies for the treatment of dry eye disease? Anything exciting in the pipeline? Anything we should know?
Well, the diagnosis is quite simple, but like anything in medicine and glaucoma or other things, it's all about data and numbers. So we do have some biomarkers that we can titer in the tears. They're already available, but they're costly. So hopefully there are some companies working on identifying more than one biomarker with one sample. So that'd be MMP9 or even osmolarity. So you can actually titer and test the inflammation of the ocular surface, thereby diagnosing chronic inflammatory dry eye. We do have imaging as well of the ocular surface. So when it's very more coming out there is the non-invasive tear breakup time, which can be done by a topographer or some sort of topography. So tear breakup time, tear film analysis, tear film volume that can be actually measured with OCT and even with artificial intelligence. So all of these numbers can help us with the diagnosis, but also with our treatment and progression evolution of what we're doing.
And any emerging therapies?
Well, obviously, they're trying to combine low-grade anti-inflammatory compounds. So different things are coming. There's a punctum plug labeled with low-dose cortisone that might be available in the next year or so, which can increase the flow of tears in the eye, but also deliver a small amount of cortisone, which is safe, but also treats the ocular surface. And so that's one of the things that's exciting. There's also a new drug that's accepted in the United States coming, I think, this year. It's a new liquid. It's called perfluoroxyl octane. So it's a liquid that minimizes the evaporation of the tear film. So that is very exciting for people who have computer vision syndrome, which is evaporation because of lower blink rate during computer work. And we don't have a lot for this because no one can try to blink faster at a computer. You can do this for a minute or two. It's like breathing faster or slower, but it's an automatic function blinking. So when we're on the computer, blinking rate is decreased, and that's very hard to manage.
But it is important to manage dry eyes. And can you tell us about any complications or long-term effects that are associated with it?
Well, very severe dry eye, like we see in Sjogren disease, but especially also in secondary Sjogren and rheumatoid arthritis, these patients have usually a lower sensation of the cornea. So they don't feel their dryness like regular people, but they will see their dryness, which is visual fluctuation. These patients are at high risk for surface breakdown, epithelial defect, corneal ulcer, neurotrophic ulcer, but even perforation. So people with severe chronic inflammatory disease, usually associated with a systemic inflammatory disease, they're at risk for these complications, ulcers, perforation, and they may present with a perforation, not even knowing they have dry eye because of lower corneal sensation, which can be a problem. So sometimes vision is the only hallmark of their dry eyes.
That's really frightening because often I'm playing a reassuring role with my patients who, come to me for glaucoma, but also have dryness or ocular surface symptoms. And, I often will tell them, this is a very bothersome condition. This is going to be, a big nuisance for you moving forward. But thankfully, it's not serious. But what you're saying is very serious. So, how about for, routine dryness without any systemic conditions? Am I doing a disservice to my patient by telling them that this is rarely, visually threatening? Or is it really only the patients with significant risk factors where the idea of having visually threatening dryness is a reality?
No, I think you're actually spot on. I mean, most people, the vast majority, have a condition that is a nuisance, and only severe dry eye. When I say severe, is people with associated condition, rheumatoid arthritis, lupus, or Sjogren, and these are the dangerous patient. And usually, just by looking at their eye, you know. I mean, whatever you throw at them, they're still dry on exam. So this is not your routine dry eye. I think the way you stated it is actually how I approach saying the vision is not a problem. You will not, get blind from dry eye, which is your, garden variety dry eye. But we can alleviate your symptoms and make this less of a bother because, once you start feeling your eyes, this is not normal. You should not be feeling your organs. So once you start feeling your eyes and have bother, well, this is where people seek treatment. So I think you're spot on. This is a nuisance, but a chronic nuisance, and it can get, under your skin a little bit because no one likes to wake up with something to do about a problem every day in, day out, week in, week out, and, throughout the year.
Absolutely. We touched on this a little bit, but I'm hoping for you to do a little bit more of a deep dive on the topic of lifestyle modifications or self-care practices that could be helpful for patients with dry eye disease.
Well, the basic things, and again, I'm not going to surprise anyone with this, but a good nutrition and regular exercise has actually been shown to be good for people with dry eye. But what I actually usually steer my patient towards are 3 or 4 things. First of all, I really noticed that relative humidity is a very big factor. That is hard to do, but a humidifier in a closed bedroom is very, very useful. Even though we have our eyes closed, we do tend to get dry eye from a fan that's from above or underground. As you may know, the animal model for dry eye, to study dry eye, is actually animal in cage with fans around. So even if they turn their back or close their eyes, they get chronic dry eye. So we should eliminate fans in the bedroom or anywhere. That's why driving cars is difficult for people with dry eye because there's a lot of wind coming. So that is one of the lifestyle things that we insist on. Relative humidity, shutting down fans, closed room humidity. So 40 to 45% relative humidity is what is useful for people with chronic dry eye. The second thing that's useful, to try to limit computer screen. Now, this is not easy for everyone. People who are working or taking breaks every now and again. No bosses like people taking breaks for dry eye. But there is a rule that we call the 20-20-20 rule, which is every 20 minutes, take a 20-minute break. And, not a 20-minute break, 20-second break, and look 20 feet, farther just to get your blinking rate normal. So again, no 20-minute break, 20-second break. So again, taking regular breaks for computer can allow you to blink regularly. The other one that's less known is making sure you get the right correction eyeglasses. When you strain, because even if you don't need glasses, but if you strain at a computer, your blinking rate goes low real quick. So if you are a little bit presbyopic, if you are a little bit myopic, hyperopic, a little bit of astigmatism, even if you don't need glasses on a daily basis, when you watch TV, when you do your computer and you have dry eye, having a corrective glasses can bring your blinking rate a little bit more to normal. Plus, having screens in front of your eye may limit some evaporation or lessen the air coming into your eye. So wearing eyeglasses sometimes can actually help in those patients. So these are small things, but wearing glasses at the computer is not a big thing and a big nuisance. Taking a few short break, hydrating well, exercising, eating well, these are pretty basic. Humidity is complicated, but I do have some patients that install central humidifier in their home, and that make a huge difference. I always tell patients there's only 2 things that cure dry eye, and it's retirement and Florida. So if you go to Florida 6 months a year in a humid environment, you take a break from computer. I actually seen people cured from dry eye just by retiring. And so that tells you how much computer work and environment plays a role. And that's the thing that we don't insist on enough. And people are, hesitant to do this because they want the drop, they want the pill, and they want the fix. But these things actually matter, and in the long run, they will make a big difference.
Great recommendations, Louis.
I would like you to prescribe me a winter in Florida every year and a 20-minute break every 20 minutes.
I've had that request very often.
I'm coming to see you tomorrow. Louis, where does psychotherapy fit into your approach to dry eye? Does it fit anywhere? Share some thoughts on that.
You mean psychotherapy for people who are depressed or overwhelmed by the disease? Is that where we're going?
No, it's not somebody who's telling you I'm, struggling with my mood. I need some help. It's somebody where you feel like that might help with their symptoms. So I don't know the answer to this. I've never done this, but I have a colleague who's felt very strongly about this in a subset of patients, and swears by it. And I don't do this enough to have, screen the literature on the topic. And I wonder if you have approached it ever in that way, or if you've heard from colleagues or the literature that this is an approach of pertinence for some dry eye patients.
Well, two things. First of all, people who this is just statistics. People who tend to have depression tend to have more dry eye, and people who have more dry eye tend to have more depression. So again, this is statistics. Now we're in the business of eyes and taking care of our patient, but I do see patients that are overwhelmed by either their chronic condition. That might be something else than dry eye. It might even be glaucoma. It might be, their diabetes. We don't, scratch that itch a lot saying, are you okay? Are you feeling okay? Are you overwhelmed? But every now and again, I see someone who's overwhelmed, psychologically or physically, but whatever is happening. But I personally do not use psychotherapy, recommend psychotherapy. And the data and research has not shown this to be very efficient. Now, there is a subset of dry eye, which is categorized in dry eye, which is, we're not going to touch on today, but is neuropathic ocular pain, which is a different diagnosis, but it's still in the box of dry eye. And this is a neuropathy that happens in the cornea, and the hallmark is actually ocular pain. Now, this is a subset of patient that probably needs more help, psychological help, and support, because it is a chronic pain syndrome, and it's a little different than dry eye. But personally, usually I do not use psychotherapy. I think the science behind dry eye has been well known for many, many years. Chronic inflammatory disease of the ocular surface. We know the players and we know how to treat. It's just a long time to take effect, plus because it is multifactorial. But I usually do not go that way, and I have not found it to be very useful or spending time on this.
You're a very busy cornea specialist. You do a lot of refractive surgery. You must have a lot of dry eye patients in your clinics. Can you share success stories, things that are encouraging? Early intervention, proper management, something that you feel should be addressed so that people have success treating these patients?
Well, the first thing, things I see a lot is patients who either have not been taken seriously about their dry eye, been seeking here and there. And I know we should not over-medicalize problems, but chronic dry eye is a pathology. And sometimes just naming their disease and explaining that they have all the criteria that fit into chronic inflammatory disease, and the fact that it's inflammation that's the hallmark of the disease explains also why all the drops they've been using does not work until we break down the inflammation. And once they kind of understand this part, they take part of their treatment a bit more. The success stories about beside the retiree Floridian, the other success story is someone who actually take charge and take part of their treatment. It is a symptomatologic disease, and so they have to treat their symptoms. And so they have to put drops whenever they need it, understand that if they do a lot of computer, they may need a lot of drops during that time, and to adjust between work, activities, so on and so forth. So someone who actually understand that they need to work on humidity, activities, screen time, and follow the plan, this is where we get success stories. People who come in and only choose one or two of the 5 things we recommend will only have 2 out of 5 success. So people who actually take a bit of everything and stick with this, you usually end up having some relief. But again, it takes time, and they have to have confidence on your diagnosis and kind of that stepwise approach plan. Knowing there's always a next step further is good to them, for them to know that at least there's something else coming if I'm not comfortable at that stage.
Great. How do you envision the landscape of dry eye disease management evolving in the coming years, particularly any advancement in technology, therapeutics, research?
Well, there's good things, and there's also, social thing, which is population is aging, population is increasing, and ophthalmologists and optometrists are increasing, but not as a higher rate. So there are people left in the middle that are not necessarily assessed or treated. So I do believe that sharing that burden with optometrists to get people diagnosed and treated is super important. There's also advance in telemedicine and even artificial intelligence that can allow us to examine people from a distance. And like I've discussed earlier with imaging and even biomarkers, and even with a questionnaire, it might be quite easy to diagnose dry eye with not necessarily even being present. And so kind of screening people faster, easier, and get them there. Are you inflammatory or you're not? We know these are more serious dry eye than their garden variety of just dry eye symptoms, whereas dry eye disease need medical attention.
Louis, this has been a really interesting chat about a topic that's relevant to all of us. And I feel like it would be really useful to, kind of have like a take-home message from you. And any of the learners who've worked with me in my clinics know that at the end of each day, we do a little take-home session where everybody shares their favorite pearl from the day from the patients they saw. And I'm wondering if you can do that for us today. Your favorite take-home messages about dry eye for all the listeners out there treating dry eye or dealing with dry eye. Please share your top take-home.
Well, my top take-home is if someone has symptoms of dry eye and signs of dry eye on exam, and they're using lubrication on a regular basis and they're not satisfied, by design, they have inflammatory disease and they need to go to the next step. A lot of people hesitate. They'll try 2 or 3 eye drops. But if you're not satisfied with lubrication, you need medication. And that's my take-home message.
So meaning anti-inflammatory, some kind of anti-inflammatory?
Correct. So if you have blepharitis, now you might need lid treatment, you might need doxycycline, you might need cortisone. If you have tear deficiency, then it's cyclosporin, lifitegrast, and cortisone. So again, lubrication is step 1, but not for chronic disease. You have to jump to anti-inflammatory real quick, and this is where I get success stories. People say, I've been putting eye drops for 5 years, and after a few months of this medication, I am much, much better. So there's no side effect in cyclosporin besides, some maybe local irritation or burning upon installation early on, but there's no side effects. So people always hesitate to use these compounds, but they take 2, 3 months or 4 to take effect. So the sooner you actually start them, the sooner you'll have a response. And stopping them later is fine. I mean, you can always stop stuff, but early diagnosis, early medication for people who have chronic inflammation is what it needs to be done earlier, quicker.
So as we wrap up, Louis, we always like to hear a little bit more about our guests. So when you're not fighting the beast of dry eye or corneal disease, what are you doing? What are your favorite things to do outside of work?
I like to be outside, not that I'm looking for humidity, but I'd go to Florida too. I'm actually a swimmer and a cyclist. So again, recently I've been tearing. I guess I'm going too fast cycling. But yes, you go to the pool, it's irritative for your eyes. You go outside, there's some wind. But I like sports. I like to stay in shape, and that keeps me sane.
I think you're missing an opportunity to share your amazing recent open swimming experience. You don't just do normal sports or normal swimming. Can you say a few words about your recent open swimming experience?
Recently with a colleague of mine, we swam the Escape from Alcatraz in San Francisco, where a boat drops you near the prison of Alcatraz, and like a convict, you have to swim to the shore. So yes, I made it.
Awesome. Well, I can't think of a topic that's as relevant to really anybody providing eye care as dry eye. I listened with intent, and I really appreciated so many of your pearls. So thank you for your time and expertise tonight. That was a great chat.
Well, thanks again for having me. That was very interesting, and invite me again.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we will try to incorporate them into future episodes. Season 4 of the EyeCan podcast is brought to you by Baylor Ophthalmology. We thank them for their support.
Nous aimerions remercier Baylor Ophthalmology pour leur support de la 4e saison du balado EyeCan. Thank you from the Canadian Ophthalmological Society.
EyeCan is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
EyeCan is available on Apple, Spotify, and Google platforms, and of course, through the COS Practice Resource Center.
Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more.
Thank you for joining us this week. We look forward to bringing you more episodes.